Now, as we'll talk more about later, we used to say up until recently that kids never went V-fib. They only went flatline, and that was all there was to it. Depending on which study you look at, in anywhere between 8 and almost 20% of the time when children arrest, they are actually initially in V-fib. And that is much more than what we ever thought. What they actually feel is that by the time somebody gets around to hooking the child on a monitor, yeah, the kid is in flatline. But in almost 20% of the time, if they're initially in V-fib, is being described as a window of opportunity. Which means if you show up and the child is in V-fib, much as with adults, if they get promptly defibrillated, much like adults, they have a really pretty decent chance at actually returning to life. Versus flatline, which, as you know, unfortunately has a universally awful outcome. Therefore, there's two ways to use a defibrillator. Defibrillation begins with D. Dead people begin with D. Therefore, if you are dead, you get defibrillated. That's when you put the paddles on your chest, you push the buttons, the electricity is released, and again, you essentially stop the heart and hopefully come back with a rhythm that you like. The difference is if we cardiovert them. Cardioversion begins with C. Conscious or crashing begins with C. Therefore, people that are still conscious or they're crashing but not yet dead get cardioverted. The rationale is that you have a rhythm. You may not like it, but having something is certainly better than having nothing. Therefore, in people that are conscious or crashing who need electrical therapy, we go ahead and we cardiovert, where you push a couple extra buttons, you allow the monitor to pick a good time for the energy to get released. Again, maximizing your chances of coming back with a rhythm that you like. Pacing, if you've ever had to externally pace someone, what you come away with is a couple things. Number one, it hurts. If you've seen patients that are awake and having this performed as their chest goes like this, and they tell you ever so subtle wording like, take those off my chest, I'd rather die. Quick reminder, people who can complain about being paced probably don't need to be paced. Now, what does this involve in regards to pacing? Number one, the energy for children is exactly the same as it is for adults. You place the pads in the same place, the energy is the same. The key is whatever energy you choose, is it actually working? Now, the problem is people see this and the muscular contraction and they assume that that means it's working. The problem is you need to look on the inside to make sure that the EKG or the heart muscle is working as well. The reason being is that I could play a really bad joke on y'all. I could go down to the morgue, take a person who's been dead for 2 days, put them in a hospital bed, throw them in a gown, hook up external pacing pads, crank up the energy, and you could watch them dance. However, are they coming back to life? Absolutely not. Therefore, seeing the outside move is good. More importantly, make sure that the EKG and the inside is moving as well. Now, what specifically regarding children is the whole idea of pediatric versus adult pacing pads. They do make pediatric pacing pads. However, a couple things you need to know. Number one, they're expensive. Number two, they only are sold in boxes of 5 to 10. And number three, they expire. And they expire long before you'll actually open one, not to mention 5 to 10. If you work in pediatric critical care, pediatric transport, you probably ought to have them. Why? Because you actually might use them. But for run-of-the-mill pediatric units or for emergency room settings, in the majority of cases, I recommend the adult pacing pads. The reason being, number one, you use them on adults. Number two, if you look at the literature, you can use the adult pacing pads on a little kid. What the literature will teach you is that as long as the child is big enough that you can put one pad on the front, one pad on the back, you can actually use the adult pacing pads on a little tiny child. If you work in pediatric critical care, where you might actually use the pediatric pacing pads, they are a very appropriate purchase. But again, for the vast majority of healthcare workers who are going to use pacing, the adult pacing pads work just well. Best case in point, if you work in the emergency room. A 2-year-old comes in after overdosing on mom's verapamil. The child has a heart rate of 25. You can temporarily externally pace the child with the big people pads, and again the same energy, until you can get the heart rate up by other means. However, we said earlier that actually the only thing that really appears to make a difference in bringing people back is defibrillation. However, if you look across the world, the big trend, in addition to different and newer waveforms and defibrillators, is especially the emphasis is on the automatic ones. And the rationale being is that both, as we'll show you, in the hospital setting and out of hospital, especially with lay people, the more people who have access to a defibrillator, the better chance that people have of actually having it used. Now, there's several researchers that are currently recommending that in a hospital setting, including pediatrics, as we'll show you, that all fancy defibrillators should be taken off of the units, except in units who actually know how to use the darn thing. Which means surgery, emergency room, intensive care, units who know how to use a conventional manual defibrillator should have a defibrillator. Psych units should not have a defibrillator. What these researchers are recommending is that on these units that we should place automatic defibrillators. The rationale being, think about calling code blue med-surg, code blue pediatrics. By the time the resuscitation team drops doing what they're doing, finds where the patient is, if indeed they're in V-fib, several minutes have elapsed by the time that this person could have been shocked. And as we described earlier, either in children or in adults, every minute that goes by, your chances of coming back drops by 10%. Therefore, if we can train pediatric nurses, floor nurses, as we'll show you in just a couple minutes, they now teach middle and high school students how to use these automatic defibrillators. If indeed we can train them to use them, and again the patient can get shocked, their chances of coming back are substantially better. It used to be back in the late 60s that only physicians could defibrillate. Nurses were not allowed to touch the defibrillator. Then they quickly learned that who was at the patient's bedside at 2 o'clock in the morning was not the physician, primarily it was the nurse. Then they taught nurses how to use the defibrillator. In the 70s, they put paramedics through a several hundred-hour course to teach them how to use a defibrillator. In the 90s, they taught basic EMTs how to use a defibrillator through a 4-hour course. And now, in many parts of the country, they're teaching middle and high school students how to use automatic defibrillators because they're popping up everywhere, from airports to shopping malls to, as we'll show you, Las Vegas casinos. In some areas of the country with high-risk cardiac patients, they are sending patients home with their own defibrillator. A couple years ago, the FAA made a mandate that said every commercial airliner that has one pilot, one flight attendant, one passenger has to have an AED on board. You need one person to fly the plane, one person to drop dead, one person to do something about the person who dropped dead. And as you take a look at the literature, there actually have been some very amazing success saves, whether you're flying across the sea or flying across the states. However, interesting medical trivia fact, and that's if you were going to have to drop dead. Outside of the intensive care unit or the emergency room where someone is standing there poised with the defibrillator, where is the best place to drop dead? And it actually is in a Las Vegas casino. Because in the Las Vegas casino, a couple things apply. Number one, the eye in the sky. The eye in the sky, as you know, means nothing happens in a casino that they do not know about. And in the Las Vegas casino, they have trained the blackjack dealers and the security officers to use an automatic AED. And in the event that someone arrests, within seconds they have pounced on them with an AED, and success rates rival that of the intensive care unit. Meaning that if you are in a casino, you experience chest pain, whatever you do, do not leave the casino. Because if you drop dead outside of those air-conditioned doors on the very sunny street, you are dead. That's all there is to it. Whatever you do, do not leave the casino.